Hi, my name is Katie Connor. I've been working in PA education for about 10 years now. I'm also an orthopedic surgery PA in Charleston, South Carolina. Today, we're going to be talking about our neurology unit. This is part of our 13-part series to help make didactic year a little bit easier and help you to ace your boards. Let's take a look at the objectives for this unit. I've separated them out into brain-related disorders and systemic disorders. But before we get to either of those, I just want to do a quick review of the cranial nerves. If you'd like a more in-depth review for these, you can check out the video that I posted in the anatomy section on the head, the brain, and the neck, and that will give you a much more in-depth review of these. The mnemonic that I like to use, because I like rhyming things, on old Olympus towering tops, a Finn and German viewed some hops. This is in order. 1 is olfactory, 2 is optic, 3 is oculomotor, 4 is trochlear, 5 is trigeminal, 6 is abducens, 7 is facial, 8 used to be called the auditory, but is now called the vestibulocochlear. 9 is glossopharyngeal, 10 is vagus, 11 is spinal accessory, and 12 is hypoglossal. Just as kind of a heads up here, the boards are not going to give you nitpicky questions to say, what muscle is innervated by what nerve? They're going to be looking more at the clinical correlation of these cranial nerves to certain disorders. Another mnemonic that I think you'll find helpful is to remember, is the nerve, does it function as sensory, motor, or both? So some say marry money, but my brother says big brains matter more. So that can help you remember what that nerve does. So here's our quick review on cranial nerves. We'll start with cranial nerve 1, which is the olfactory. That's going to be sensory only for smell because you smell a fire before you see a fire. So that's cranial nerve 2, our optic for vision. Then we're going to skip to cranial nerve 8, which is the vestibulocochlear. That's going to be sensory for hearing and equilibrium. So all 3 on this slide here are going to be sensory only cranial nerves. Next, let's go to 3, 4, and 6. Cranial nerves 3, 4, and 6 function in our extraocular movements. When you're doing your cranial nerve exam on your patient, you're asking them to follow your finger as you go through the quadrants with just their eyes, and you're looking for fluidity in those extraocular movements. The mnemonic for this is LR6, SO4, all the rest are 3. So that's lateral rectus is 6, superior oblique is 4, all the rest are 3 is going to be oculomotor. Ocular motor also has a special parasympathetic function in lens accommodation and pupil constriction. Next, we have our trigeminal nerve. And to simplify this one really quick here, sensory here with the ophthalmic branch, sensory here with the maxillary branch, and sensory here to the mandibular branch. The mandibular branch also has 2 other important things about it. The muscles of mastication are time muscles. Temporalis, internal pterygoid, masseter, the external pterygoid, those are our muscles of mastication and a great exam question. You also have the lingual branch of the trigeminal nerve. This will give us sensory to the anterior 2/3 of our tongue. So those are kind of just a simple summary of the trigeminal nerve. Let's talk about our first disorder of the cranial nerves is going to be trigeminal neuralgia, also called tic-douloureux. Let's look at the etiology first. You're going to see on most of these slides today that I will skip to the etiology first, so I'm trying not to confuse you on that. The etiology for this one is going to be a compression of cranial nerve 5 by the superior cerebellar artery or an AV malformation at the pons. It can also be associated with other neurologic disorders like multiple sclerosis, an acoustic neuroma, or a glioblastoma. For the history for this, the patient is going to present with this lancinating pain, the severe shooting pain along the trigeminal nerve distribution. Usually it's going to be the maxillary or the mandibular portions, and anything that causes movement of that area will worsen their pain, so chewing or talking. On physical exam, pretty simple here, they'll be tender over that area. Usually this affects individuals in the 5th to the 7th decade, so 50 to 70 years old. Diagnosis for this one is the same one as treatment. That's kind of nice. So the diagnostic test for this one is a carbamazepine trial. Carbamazepine is an anticonvulsant medication that reduces the nerve transmission. So if their symptoms get better on a trial of carbamazepine, there's your diagnosis and your treatment. So your first line treatment is Tegretol or carbamazepine. Next, let's go back to our cranial nerve. So facial nerve And the facial nerve, as simply as I can put it, is going to be all of the muscles of facial expression. And then there's three that are kind of important for the next disease that we're going to talk about, which is Bell's palsy. In Bell's palsy, this is a paralysis of the facial nerve. So a couple key features of this one. The stapedius muscle is responsible for dampening sound vibrations going to the ear. If you have paralysis of this muscle, those sound vibrations are going to sound very loud. So hyperacusis is a characteristic of Bell's palsy. The facial nerve also controls our lacrimation. So the patient with facial palsy will have a lack of tear production or lacrimation. The chordae tympani branch of the facial nerve. This will give taste to the anterior 2/3 of our tongue. Remember that the lingual branch, the trigeminal nerve, we just talked about that. That's sensory to the anterior 2/3 of the tongue, but chordae tympani is going to be taste. So let's look at Bell's palsy. Etiology first. Bell's palsy is a paralysis of the facial nerve, cranial nerve 7. What causes it? It's idiopathic in most cases. We don't know. We do know it's associated with extreme cold temperatures to the face, can also be associated with herpes simplex, Epstein-Barr, Lyme disease, and HIV, but idiopathic is the #1 cause. For the history of this, everything that can happen when you have paralysis of the facial nerve, that's what's being described here. So unilateral facial paralysis that develops over hours to days, they'll have that decreased lacrimation like we talked about, decreased taste because of the chordae tympani branch, hyperacusis because of the paralysis of the stapedius muscle. A key point here is that facial numbness is very rare in Bell's palsy. Well, it's actually very common in a CVA. So if your patient presents like this in the picture, you need to try to figure out, are they having a stroke, a CVA, or are they having Bell's palsy? On the physical exam finding for this one, Bell's palsy, this is a key point, will affect both the upper and the lower face, whereas a CVA is only lower face. So let's talk about why that is. The upper face has a dual hemisphere innervation. A CVA only occurs in one hemisphere, but the facial nerve, if it's a peripheral nerve where it's paralyzed, will affect both the upper and the lower. So remember, CVA also gets innervation from the other hemisphere. So that's why the upper part of the face is not affected in a stroke, but it is in Bell's palsy. So the upper and lower face are affected. They cannot wrinkle their forehead. They cannot close or blink their eye. Facial nerve paralysis, again, like I said, is muscles in the upper and the lower face. They'll have a flattened nasolabial fold. Their mouth will be drawn downwards. Key point here, they will have no deficits in speech, vision, balance. Remember that those are more likely to be associated with a CVA. Their mentation and their mental status will also be normal. It will be intact. Whereas in a CVA, you usually see deficits in the mental status or the speech, the vision, the balance part. Most commonly, this is associated with pregnancy. Why? We don't know. It's idiopathic, but it can happen at any time, any age, any ethnicity, any gender. If it lasts more than 3 weeks, you can order a nerve conduction study, but that's usually excessive. This can go away on its own. 90% of cases will self-resolve within 3 weeks to 6 months. You can try using steroid medications. They're not very effective. The biggest thing that we want to do for Bell's palsy patients is prevent a corneal ulcer. So we may use eye drops or tape the eye shut on that side because they don't have that blink reflex. So that's the biggest thing, is self-resolving. Counsel the patient. This is socially bothersome to patients to have their face look like this. So counseling and reassurance that this will get better, and then preventing that corneal ulcer. Next, we'll talk about the vagus nerve. The vagus nerve has tons of functions throughout the body, but remember that this one is responsible for all your pharyngeal muscles, but it has important functions for digestion, cardiac function, and pulmonary function through those plexi. Next, we have our glossopharyngeal, which is going to be cranial nerve 9. In the glossopharyngeal, the way that I remember this one is G for gag. It's all the way at the back of the throat there. Glossopharyngeal will give taste and sensory to the back posterior 1/3 of the tongue. We already know that our anterior 2/3 of the tongue are going to be innervated by the facial nerve, that chordae tympani branch for taste, and sensory from that trigeminal branch, the lingual branch. So that's your tongue muscles, or glossopharyngeal. The hypoglossal actually innervates all of the intrinsic muscular. So this is going to be a motor to the tongue. So the glossopharyngeal and the hypoglossal work together. So all of your tongue muscles except for the palatoglossus on the hypoglossal. Spinal accessory, this innervates the trapezius and the sternocleidomastoid. But you remember that 9 and 12 kind of go together. So that's your cranial nerve review. Let's dig into the brain-related disorders here. We're going to start off with altered mental status, dementia versus delirium. Let's talk about delirium first. In the physical exam, this is what we'll talk about first. There's 5 characteristics or 5 kind of on the spectrum of how alert is this patient. So we'll start with alert. They're oriented, they're interactive, they're responding appropriately. Then we go to lethargic, where the patient requires some form of verbal or physical stimulation to become aroused and become interactive. Obtunded is the next level down. They are slow to respond even with verbal or physical stimulation. Stuporous, they only arouse to pain, a brisk sternal rub or pressure on the nail beds. That's what it takes to get them to be alert. And then comatose, no matter what you do, they're going to be unarousable. They will either have a decorticate posturing where everything comes into the core, or a decerebrate where the arms kind of flare outwards. So alert, lethargic, obtunded, stuporous, and comatose. It's important for you to know those in order. For dementia, dementia is something that's chronic and progressive. Delirium, what we're talking about here, is an acute state of agitation. They may also have hallucinations with this one. The mnemonic for what causes delirium is SMAShed. S could be sugar, sepsis. M is meningitis, mental illness or medications. A is alcohol. S is seizures or stroke. H is hyper or hypo, thyroidism, thermia, tension, and hypoxia. E is for encephalopathy, and D is for dehydration or drugs. So any of those things could cause delirium. When we're diagnosing this, there's 2 kind of useful things that you can use. One is a mini mental status exam. That's the bottom picture there. That's much more in depth of a procedure. The Glasgow Coma scale is a fast way to kind of rate the patient on how responsive they are. So that one's important. Let's look at that one. 4 eyes. You remember 4 eyes of somebody, if you're wearing glasses, somebody was being very mean and calling you 4 eyes. For eye opening, we have 4 criteria: spontaneous, to command, to pain, or no eye opening. Verbal is going to be the next one. Remember, V is the Roman numeral for 5. So it has 5 criteria in the verbal response. The patient is oriented, confused, they have dysarthria, they have incomprehensible speech, or they are nonverbal. And then the next one is motor, and that's going to have 6. So we went 4, 5, 6. Motor is the patient follows commands, localizes to pain, withdraws to pain, flexes to pain, extends to pain, and then no response. So the lower your Glasgow Coma score, the more kind of down that line towards comatose you are. The treatment for this, figure out what's causing it. If you figure out what's causing it, you want to treat that. You want to ignore any kind of hallucinations that the patient is having, try to reorient them, and remove any noxious stimuli that could be triggering this. Next, let's talk about syncope. Very, very, very common. 40% of all human beings at some point in their life will have a syncopal episode. It is more common in elderly because they tend to be more dehydrated, and that's a common cause of this. So go to etiology first. Syncope is a loss of consciousness and muscle tone for less than 5 minutes due to global hyperperfusion. So you're not getting enough blood to your brain in the most simplest terms. Vasovagal is going to be the most common. This is common when you're on your surgical rotation because you're seeing things for the first time that you've never seen before, and your brain gets kind of scared by that. Vasovagal is a response to fear, seeing blood, having pain, having extreme emotions, prolonged standing, warm or crowded conditions, and then venipuncture, either you doing it or somebody doing it to you. Vasovagal is very, very common. So for your board question, vasovagal is going to be the most common cause of syncope. Carotid sinus. If you have too tight of a collar or if a patient has been strangled, that will cause a syncopal episode. Cardiac etiology for this: atrial fibrillation, Wolff-Parkinson-White, aortic stenosis. We talked about all of those in our cardiology unit. Orthostatic hypotension, where the body isn't able to pump that blood up to the brain quick enough. This is common in dehydrated patients and pregnancy. And then finally, hypoglycemia. Hypoglycemia, just low blood sugar, can be a cause of syncope. For the history, the patient is going to say they feel lightheaded, kind of dizzy, nauseous. They may have this kind of tunnel vision, ringing in their ears, their legs feel weak. After they pass out or they have that post-syncopal episode, they'll have a headache, they may be confused, but they will always come back to normal neurologic function. On exam, if you happen to be taking out your patient's sutures and you look up and they look sweaty and pale and kind of like they're going to pass out, have them put their head down, because you don't want their head to put them down and you'll hit that table. So ask them to put their head down calmly on their arms and wait for it to pass. You cannot talk yourself out of a syncopal episode. Your body will do what it needs to do to get blood to the brain, which is drop you to the floor. The diagnosis for this: do a finger stick glucose. If it's something as simple as a low blood sugar, that's fixable. Orthostatic blood pressure measurements. And somebody who has this as a chronic condition, they're having chronic syncopal episodes, so have their blood pressure taken while they're standing, they're sitting, and in a supine position. If you suspect it might be a cardiac etiology, you can do an EKG, but you're not likely to catch that on the EKG unless they're in that arrhythmia at that very moment. So a Holter monitor will detect that over a 24-hour period, and you generally have greater success to detecting an arrhythmia on a Holter monitor. Treatment for this: Trendelenburg position. Get all of the blood going back to their brain. Lift their feet up in the air, have them lie on a bed. Give them a little bit of glucose, either the glucose gel or the tabs, or you can give them a little bit of orange juice if you have that in your office. For patients who have chronic syncope, make sure that they stay hydrated. It's important to encourage those elderly patients to stay hydrated. Also, compression stockings in pregnant women or people who are on their feet a lot, that can be really helpful in patients who have orthostasis. Next, we'll talk about concussion and traumatic brain injury. Etiology first. This is a transient neurologic dysfunction due to a traumatic force on the brain, usually some kind of direct blow to the face, to the head, to the neck. And we divide this into about 3 categories when we're talking about the symptoms. As soon as that trauma happens, we call that the acute history. So headache, dizziness, confusion, maybe ringing in their ears, they may be seeing stars, they may have kind of a delayed response as you're asking them questions, and they may have amnesia, they can't remember the trauma. The late symptoms is after that traumatic brain injury, weeks later: memory loss, poor concentration, irritability, insomnia, personality change, emotional problems. They get really happy, they get really sad, they have a hard time controlling their emotions. And then if you have repeated or long-term symptoms from this: depression, dementia, definite personality change for those. On physical exam, when this immediately happens, if you happen to be there, let's say you're working along the sidelines of a sports team, you're going to check for the pupil symmetry, check the extraocular movements, rate that patient on how alert they are using the scale that we just talked about. Are they stuporous? Are they obtunded? Rhinorrhea or otorrhea, clear fluid coming out of their ears or nose, is concerning for cerebral spinal fluid leak. If they had some kind of trauma where their neck was involved and you suspect a cervical spine fracture, you want to make sure you leave their helmet on and place them in a cervical collar to protect that. Who's most likely to have this? Somebody participating in contact sports: football, hockey, boxing, skiing, MMA. Motor vehicle collisions, these are common in when people hit that steering wheel, or any type of domestic violence. There's lots of screening tests that you can use. The King-Devick sideline test, that's one that you can just use. It's a questionnaire as you're kind of trying to evaluate that patient. If you think that they might have a cervical spine fracture, you can either get a CT or an X-ray. This is an important point here. On CT or MRI, you will note a coup contra coup pattern. The coup is where the brain went forward and hit the skull, and then it went backwards and bounced. So it can go either way, but it's a coup contra coup where you'll have lesions or sore spots on the front part and the back part where that brain bounced. Treatment for this: do not leave that patient alone. You want to remove that player from the game, and you want to monitor them. So you want to make sure that they're not having kind of a decreased in mental status. They're not changing at all. You're constantly doing cranial nerve exams to make sure that they're not having any worsening of their global function. In order to return to play, it's recommended that each of these stages, they must be asymptomatic for at least 24 hours in order to advance. So physical and cognitive rest until they're asymptomatic. Then they can progress to light aerobics, then sport-specific non-contact training, then full contact training, and then return to gameplay. We want to prevent this as much as we can by wearing a helmet. There's something important to note here called the second impact syndrome. This is in kids only because they haven't had any atrophy of the brain yet. And because they have not had any atrophy, if that brain is still swollen for the first impact and they have a second impact, you get more edema, and then the brain can actually herniate through the foramen magnum, and that can kill them. So this is if they return prematurely post first concussion, they can have brain edema and herniation. Next, we'll talk about Alzheimer's disease. This is a slowly progressive buildup of two things: beta amyloid plaques outside the nerves and tau tangles inside the nerves. This leads to degeneration of the neuron. It leads to depletion of acetylcholine and then cerebral atrophy, like you can see in this bottom picture here. This is an important point, is that it starts in the hippocampus, which is responsible for memory. That's why the first symptoms are memory. So beta amyloid plaques outside, tau tangles inside. We separate the symptoms into early, intermediate, and late. And that's a good exam question, is to ask you where that symptom may belong in. Let's start with our early symptoms. They have impairment in their recent memory. They cannot retain any new information. They have trouble with their activities of daily living. They may be irritable. Agnosia, apraxia, and aphasia are common in the early symptoms. So agnosia, they cannot identify faces. They cannot identify normal objects. Apraxia, they are unable to execute stereotype behaviors. These are things that you do all the time. When, for example, when you brush your teeth, you take your toothbrush out, you put your toothpaste on, you brush your teeth, you spit, and then you rinse. They are not able to do those stereotyped behaviors anymore. Aphasia, they have difficulty with word finding. Then we go to our intermediate symptoms. So all of the early symptoms apply, but now we still have impaired memory and cannot learn new information. But now they start to need help with their ADLs. They start to wander, they lose time and place, they hallucinate, they start to develop this kind of flat affect. They may fall, they may be up all night, so they have sleep disturbances. This is when those patients get very tough for the caregivers, especially if their caregiver, happens to be their elderly wife or elderly husband. It's important as a provider to be screening for the mental health of the caregivers and make sure that they have the help that they need. Finally, late symptoms. Now they're not able to do any activities of daily living. They become non-ambulatory, incontinent. They have no memory. They become malnourished, and usually they die from pneumonia because they're bedridden, they're not breathing as much, and so pneumonia is the most common way that they'll pass away from that. This is the most common dementia. The majority of this, 95% of this, is going to occur over age 60. There is a variant for an early onset at age 30, but that's only 5% of cases. We know there are some risk factors for this. Repeated head trauma. There's a genetic component in about 20% of the cases. Prolonged and untreated depression. Tertiary syphilis can cause this, and then prolonged Lyme disease. On MRI, these are key findings, so good exam questions. They may have atrophy, as you can see in that bottom picture there. Lesions of the white matter, and then a decrease in hippocampal volume. These are kind of specific for Alzheimer's. The way that we treat this, because they have a depletion in acetylcholine, we want to give them a cholinesterase inhibitor to kind of promote that acetylcholine being around longer. So Aricept or Exelon would be examples of that. Namenda is a medication that helps with the memory. And then this is a newer medication. Aduhelm is a monoclonal antibody that reduces the amount of beta amyloid plaques. So it doesn't cure it, but it does slow the progression. It's important also for these patients to be in physical therapy, occupational therapy, and speech therapy, because that can help to slow the progression of the Alzheimer's and give them a better quality of life as well. These are 5 other non-Alzheimer's dementias that we'll talk about. They all have to do with not having the memory. They can't retain new information. So they're an irreversible global loss of cognition and memory, but they have some kind of specific findings for these. Vascular dementia. This is a result of prolonged hypertension, hyperlipidemia, smoking, and diabetes. Depression and psychosis are common with vascular dementia. In Lewy body dementia, this is alpha-synuclein protein deposits inside the axons instead of the tau tangles. This one's associated with hallucinations, insomnia, gait impairment, and myoclonic jerks of the muscles. Frontotemporal dimension. Remember that the frontal lobe is our decision-making process. So this is tau and progranulin mutations in this one. Word finding difficulty, impulsiveness, and dyslexia. Normal pressure hydrocephalus. It's a triad, so you know it's an excellent exam question. Dementia, gait disturbance, and incontinence occur together. AIDS dementia complex. This is mostly associated with the characteristics of problems with abstraction and bradykinesia, so slowing of all the muscle movements. Let's talk about some intracranial bleeds now. So a cerebral aneurysm, this is a ballooning kind of weak area in the part of the cerebral artery, and it makes it more likely for that to rupture and bleed. This is associated with atherosclerosis, hypertension, connective tissue disorders like Marfan and polycystic kidney disease, and then obviously smoking. We know that smoking is not good for our vascular system. If this ruptures, that's when you start having symptoms. Otherwise, it's asymptomatic prior to rupture. When this ruptures, it causes an intracranial hemorrhage. The most common site of this is going to be the anterior communicating part of the circle of Willis. That's a great exam question. So the anterior communicating part of the circle of Willis is going to be 30% of the location of our cerebral aneurysms. Posterior communicating, middle cerebral artery, and then basilar are less common areas for this. So when it ruptures, that patient presents with severe headache, facial pain, they may have a seizure, they may have double vision. You're going to see some concerning physical exam findings, nuchal rigidity, so Brodzinski and Koenig signs, altered mental status, visual deficits, aphasia, and hemiparesis, depending on where this occurs at. Epidemiology for this is typically an older population, so 55 to 60, because a lot of those risk factors like atherosclerosis and hypertension, they take a while to start to damage that artery, so it's not instantaneous. An MRA, that is going to be highlighting the vessels, so that's much more specific than an MRI. So an MRA is the most specific and sensitive for this because it actually highlights the vessels. Endovascular coiling and clipping can be used to close off that aneurysm. Coiling is the preferred method. If this is untreated, it leads to a 65% mortality because you build up blood into the brain. These are going to be specific intracranial hemorrhages, and there are 4 that we'll talk about. These are commonly tested on the boards. An interparenchymal hemorrhage. This is most commonly caused by hypertension, and this is going to be a hemorrhage from the penetrating artery in certain areas of the brain, the putamen, the thalamus, the pons, the cerebellum. Subarachnoid hemorrhage. This one is really specific. A thunderclap, sudden worst headache of their life. They may lose consciousness with this one. This is going to be most commonly attributed to a saccular aneurysm rupture. Epidemiology for this one, smoking, hypertension, polycystic kidney disease, Marfan, everything that we've already talked about. Epidural hematomas are emergencies. These are fatal if they are untreated. This is some kind of trauma to the head. These are important points here. Remember the pterion, the kind of soft part in the skull here? You have the middle meningeal artery, which runs in that area. So this is a fracture of the pterion, a laceration to the middle meningeal artery. They will lose consciousness, then they will come back into a lucid state, then they will lose consciousness again, and then that's usually when they die. This is a fast bleed. This is usually in teenagers. Some kind of sports trauma can also be associated with car accidents if their head hits the steering wheel. But look for some kind of direct trauma. A subdural hematoma is a slower bleed. It's a venous bleed. This is a tear in the bridging veins from the brain to the skull. This is more common in babies and in elderly. And usually it's going to be an elderly person in the question who fell or who was in a car accident. And then a week or so later, they start kind of acting not like themselves. So it's usually days to a week or so after the trauma that you start to see this altered mental status because it's a slower bleed. A subdural hematoma is the most common intracranial hemorrhage. Diagnosis for this, you really have 2 ways. One is a CT scan, and a CT scan is usually sufficient for imaging because you can see an example of this on this picture. If the CT is inconclusive, you can do a lumbar puncture, and on that lumbar puncture, you should see blood because you're having an intracranial hemorrhage. Treatment for this, if it's an aneurysm, you want to clip or coil it. You want to drain it if it's having a buildup in that intracranial pressure. You want to have a way to release that pressure by draining that off. This is the NIH stroke scale. By no means do you have to memorize this, but this is a way to rate a patient to determine, are they having a CVA? Is it mild? Is it moderate? Is it severe? Is it unlikely that they're having a CVA? You're going to ask the patient a series of questions. You're going to determine how alert they are, ask them some motor functions. Can they do these certain tasks? And then you'll rate them. So the higher the NIH stroke score, the more likely it's a severe CVA. The lower the score, the more close you are to normal mental status. Let's talk about a TIA, also called a mini stroke. In a TIA, this is a transient ischemic attack, not infarction. This is a neurological dysfunction that occurs for less than 24 hours from ischemia, not infarction, due to a narrowing of the cerebral blood vessels. Atherosclerosis is going to be your exam answer. What's the most common cause of a TIA is atherosclerosis. Diabetes, hypertension, smoking, hyperlipidemia. We know those are all risk factors for any type of cardiovascular disease. But by definition, they return to normal. History of this, they may have a transient monocular blindness due to ischemia to the optic artery. They may have changes in behavior, speech, gait, and memory, just like you would have in a CVA. On physical exam, ocular dysmotility, an asymmetrical smile, asymmetrical tongue protrusion, weakness and shoulder shrug or turning your head, visual field deficits, unilateral arm weakness, and slurred speech. Again, all characteristics of a stroke. But the NIH stroke scale and all of their function returns to normal within a 24-hour period. The CT or MRI will show that there's no area of infarction. An MRA is important to get after this because you're looking for the vessels that are becoming narrowed due to that atherosclerosis. So the immediate imaging is going to be a CT. Afterwards, you can get an MRA to determine, are they at high risk for a CVA coming up in the future? Treatment for this. This is a warning sign. This is a warning sign of an impending stroke that will occur in 33% of patients within 1 year. So we kind of call this our come to Jesus moment here. Hey, we need to do something different here. Antiplatelet medications. We need to get them on some kind of anticoagulation. Stent. If the area is very narrowed, we can stent that. Lifestyle modifications. If you're smoking, stop smoking, start exercising, stop drinking so much. Really try to improve those modifiable risk factors. Now let's talk about a CVA or a stroke. So we talked about a TIA is transient, CVA is not transient. Let's go to the etiology first. A TIA was ischemia. CVA is infarction or death of that brain tissue. The risk factors that we know are associated with this. If you've had a TIA, you're 10 times risk for this. Somebody with hypertension and AFib is at 6 times risk. Somebody with heart disease is at 4 times risk. Diabetes is 3. Smoking is 2. This one is interesting. If you have a migraine with aura and you're on oral contraceptive pills, you're at higher risk for this, but this is minimal. You can have an ischemic or a hemorrhagic CVA. Ischemic, meaning you're not getting enough blood to that area. So atherosclerosis is going to be the #1 cause, and this is 85% of CVAs. Atrial fibrillation is also a very common cause of stroke. We talked about that in the cardiovascular unit. You can have a fat embolism from femur fracture. You can have an air embolism from an IV line that runs dry, and you can have an amniotic fluid embolus from a traumatic labor. Those are not that common. Just remember, atherosclerosis and AFib are going to be your more common causes. Hemorrhagic is only 15% of CVAs, and the hypertension is going to be #1 cause for that, prolonged hypertension. In the history, change in vision, speech, motor, sensory, headaches, or seizures are common in the presentation for these. The patient will present typically with hypertension, over 220 systolic. That's the body's compensatory measure to try to perfuse that infarcted brain tissue. So that's the body's way of trying to compensate for this. You may note cranial nerve deficits, pronator drift. As you ask that patient to close their eyes, they'll have pronator drift. Abnormal finger to nose. Remember the Romberg test, you have them hold their arms out, feet together, and they'll fall. Please don't do that with a patient. Do the finger to nose instead. You don't want your patient falling. They may have a facial droop, hemiparesis, dysarthria, where they're having poor word articulation, and then neglect, where they actually kind of just ignore one half of their body. Epidemiology for this is going to be over age 65. Typically, there is a higher risk in African Americans because they have higher risk for risk factors like hypertension, diabetes, but this can happen in any ethnicity. You're going to do that NIH stroke scale to evaluate what is the severity of this CVA or even the likelihood that they're having a CVA. CT is your answer choice. What is the #1 diagnostic evaluation for a CVA? It's going to be a CT. It's definitive, it's fast, and it's going to be your first diagnostic. An MRA is something that you can do later on, but the CT is going to be our first one. You may want to do a coagulation panel, see if they have a hypercoagulable state. An EKG, if you're thinking that this may be related to atrial fibrillation. For treatment for this, you want to allow them to have that hypertension because they're having perfusion. You want to gradually lower that blood pressure. The goal here is to try to salvage the penumbra, which is the area that's surrounding the infarct. You want to give them oral aspirin within 48 hours. This has been shown to reduce the mortality. You can use a clot busting agent, so fibrinolysis, so RTPA. There are some criteria for this that are important that the patient has to meet in order to get that medical, that pharmaceutical clot busting agent. They have to have their last known normal be within 4.5 hours. This can only be given in an ischemic CVA. You do not want to give a clot busting medication in somebody who's already bleeding. That's a common exam question. So fibrinolysis can only be performed in a patient who is having an ischemic stroke. Their blood pressure must be less than 185/110. They can't be on anticoagulation. These are now getting into relative contraindications. No prior CVA or AMI within the last month, no prior intracranial bleed. If the fibrinolytic is contraindicated or ineffective, they can do a mechanical thrombectomy where they go in physically and take that out. You have up to 24 hours to do that. After the stroke, physical therapy, speech therapy, occupational therapy are really important. Get them on an antiplatelet medication and a statin upon discharge because you want to prevent any future strokes. This is a kind of a workup of the areas, the arteries that may be affected in strokes, and what are the things that you may see in that history. So for your exam, they may give you, the patient has weakness in their leg and sensory loss. What is the vessel to be most likely affected? The anterior cerebral artery is going to be most associated with leg weakness and sensory loss, imbalance, and if it's left-sided, they'll have an expressive aphasia. The middle cerebral artery is going to be most likely associated with face and arm weakness and sensory loss. They will have eye and head deviation towards the area of the stroke. If it's left-sided, they'll have that expressive aphasia. They cannot communicate what they're trying to say. If it's right-sided, they'll have hemi-neglect. They neglect half of their body and they can't complete tasks. So apraxia is the other word for that. In a posterior cerebral artery, remember this is going to be the occipital lobe. So you'll see vision deficits on this one. So vision side, on the same side bilaterally, homonymous heminopsia. I apologize. I know I butchered that. They cannot recognize faces. They cannot read, and they have a receptive aphasia where they can speak what they want to, but they don't understand what you're saying to them. A vertebrobasilar stroke. They may have double vision or blindness. They may have vertigo or nystagmus, dysphagia, dysarthria, loss of pain and temperature sensation. That's pretty specific to the vertebrobasilar. An important point here about the basilar artery itself, it's prior to the circle of Willis, so you don't have that collateral circulation there. Basilar artery CVAs have a 95% mortality because there's no collateral circulation. Lacunar infarcts. These are the ones that will have the least devastating consequences for a CVA. They will have motor weakness or sensory loss, but not both, in the arm, the leg, and the face. They will have no deficits in language, vision, or cognition. This is going to be an infarct in one of the little tiny pontine arteries that goes to the brain. There's a ton of collateral circulation there. That's why they don't usually have these really bad deficits. So lacunar infarct is the lowest mortality, basilar artery is the highest mortality, and just kind of remember those specific things about those vessels. Next, we're going to talk about our headaches. We'll start with migraine headaches. You can see on the screen here, there's this kind of vibrating area of light that's called a scintillating scotoma. In a migraine headache, this is caused by a genetically altered blood-brain barrier permeability. So they get increased inflammation in the meninges. They get these oversensitive meninges. People with migraine headaches, they know what their triggers are. So stress, hormones, fasting, barometric pressures and changes in the weather, storm fronts coming through, certain odors like perfumes, lights, bright lights, alcohol, smoking, foods that are high in MSG, aspartame, red wine, cheese, hot dogs. So you ask your patient, hey, if you're getting these, let's keep a diary of the triggers, because we know that people have specific triggers, so we can try to avoid those. In the history of this, the patient will experience this kind of prodromal state where they're kind of lethargic. Then they develop the aura. The aura can be visual, like the scintillating scotoma. They can have odd paresthesia, so numbness and tingling in their face, their hands. They can become hypersensitive to smells, to sounds, and to light. They may have difficulty speaking, and they may get dizzy. When the headache appears, it's going to be gradually worsening. This is important. It is pulsatile and it is unilateral. Those are two important key features of migraine headaches. They're pulsatile and they're unilateral. Once the headache resolves, the patient will experience a postdromal state where they kind of feel hungover. They just kind of feel lethargic. On physical exam, there's not a whole lot of specific ones for this one, but your patient will come in probably wearing sunglasses. They'll ask you to turn off the lights in the room. They'll talk kind of quietly. They may be squinting. They may have sluggish pupil reactivity, or they may not even let you shine a light in their eye. For this, it is highly genetic, and females are going to be more common for this because of the hormonal influence for this. Most people who get migraine headaches start in their teens and 20s. If somebody starts with migraine headaches later on in life, that's a red flag for they could be something else like a brain tumor. The diagnosis for this is really important that you know these numbers. So we talked about a diary for the triggers. If they're over 50 and it's a new onset or it's a change in their migraines, you can get an MRI to rule out something like a brain tumor. If you have a migraine without aura, by definition, you have to have at least 5 of these in your lifetime, and their migraines last 4 to 72 hours. These numbers are important. They must have at least 2 of the following characteristics: unilateral, pulsatile, severe in nature, worsens with activity, and at least 1 of the following of these characteristics: nausea, vomiting, photophobia, sensitivity to light, or phonophobia, sensitivity to sound. If you have a migraine with aura, your definitions are you must have at least 2 of these episodes within a lifetime. The aura that you experience prior to the migraine must be fully reversible. It goes completely away. And the migraines last about 5 to 60 minutes. So all of those criteria are important. We have lots of treatments for migraine headaches, and we kind of separate these into abortives. If you have the headache, how do we get you out of it? And preventatives. If you have over 4 migraines a month, you can consider a preventative. The abortives can range: anti-inflammatories, the triptan medications, serotonin 5-HT1F agonists. These are for people who have cardiovascular risks and can't take the triptans. You have ergo alkaloids. Migranol is an example of that one. And then you have butalbital combinations, things like Furoset, and then opioids if it's really severe, but we're trying to get away from that. For the preventatives, we've had a lot of developments in medications for migraines over the last couple of years. Calcitonin gene-related peptides, so CGRP monoclonal antibodies. These, an example of this would be Emgality. These are very potent vasodilators, and they help to resolve and keep that blood vessel patent and open. A CGRP receptor antagonist, they're interesting because they're both prophylactic and abortive. So they're kind of a nice novel treatment. Propranolol is a beta blocker. Verapamil is a calcium channel blocker. Those can also be used as preventatives. Tricyclic antidepressants like amitriptyline, valproic acid, Depakote, topiramate or Topamax. That one kind of makes you a space cadet-y. So, they call it Dopamax, Topamax. You don't really see a lot of people on that anymore. And then Botox can be given to the scalp and the temple. So make sure you know all of those about migraine headaches. That's really commonly tested. Cluster headaches. For cluster headaches, this is dysfunction in the hypothalamus, and they get oversensitive to histamine. So triggers for these would be histamine is associated with, seasonal allergies, smoking, stress, eye strain, and alcohol. People who we see for cluster headaches, kind of the typical is going to be onset at age 30, younger men, heavy smokers and drinkers. This is pretty rare. This is only 5% of all headaches, but you think about a younger man who smokes and drinks. In cluster headaches, they are severe. They're unilateral, periorbital, around the eyeball, and they present with this stabbing pain. Usually it wakes the patient out of their sleep from the early morning. On physical exam, I think about this patient as kind of drippy. Everything's drippy. Scleral injection, they'll get this really red eye. Miosis, ptosis, their eyelid kind of droops. Lacrimation, rhinorrhea, facial sweating, and eyelid edema. So everything's kind of drippy. Diagnosis for this number is important. At least 5 of these headaches have to occur during the lifetime. The headache lasts 15 to 180 minutes. These clusters can occur up to 8 times a day. The clusters last 6 to 12 weeks, usually associated with seasonal allergies, and the clusters can occur several times a year. By definition, they have to have at least one of the following characteristics: scleral injection, miosis, ptosis, lacrimation, congestion, rhinorrhea, facial hydrosis, or eyelid edema. That's an important characteristic. We have abortives and preventives also for cluster headache. Abortives, high flow concentrated oxygen. That is your first line treatment. You should always pick that as your first line answer choice. They also can use triptans. They can also use the ergo alkaloids, just like we did with migraines. You can use Emgality, that was that CGRP monoclonal antibody. And then prednisone can also be helpful. For preventatives, calcium channel blockers and lithium, we don't know why, are good preventatives for these. Tension headaches. You all have had this at some point in your life. You may have one right now. This is going to be 90% of all headaches. Females will be more common than males because of the hormonal kind of contribution for that. So mild to moderate in nature. They may have pressure, pain. This is bilateral. Remember, migraines and cluster are unilateral. Tender in a ball cap distribution. They may have some paraspinal cervical muscle tenderness. You think about how you feel when you're kind of staring at a computer all day, your neck gets kind of sore. This is due to hypersensitive pain pathways in the brain. Common triggers are stress, PA school, prolonged head and neck positions, eye strain, prolonged computer glare, and teeth grinding. If people wake up with a headache in the morning, they've probably been grinding their teeth at night. Diagnosis for this: at least 10 headaches per year. Headaches last 30 minutes to 7 days, and they must have at least 2 of the following characteristics: non-pulsatile, bilateral, does not get any worse with activity like a migraine does, no nausea or vomiting, no photophobia or phonophobia, because those are characteristics of a migraine. Treatment for these can range on how severe it is: anti-inflammatories, Tylenol, your butalbital combinations. Try to get eye rest from the screen time, hot and cold packs on the eyes and neck, and make sure that you're fully hydrated, because dehydration can be a common cause of headaches. That's our first portion of neurology. Hopefully this was helpful for you. If you would like to learn more, we have 2 options. You can either choose to do the full review PDF, and that's the part 2 of the video. If you'd like to learn even more, we have a clinical pearls exercise and an exam for this. Let me kind of show you what those look like. This is an example of the clinical pearls. This is a matching exercise that takes the most highly tested concepts about that disorder so that you can match them and quickly learn what the buzzwords are for those diseases. We have 2 different levels for the exams. We have a clinical year, or a didactic year, which is going to be much more simplistic in nature. There's 4 answer choices. You will get an email of anything that you answered incorrectly. And then we have a board level. This is a much more difficult level. This will be 5 answer choices. Again, you'll get an email for anything that you answered incorrectly. The lawyers make me say that this is not for medical diagnostic purposes. This is for educational purposes only. I want to thank you for watching. I hope that this was helpful for you, and I hope to see you for part 2 of neurology. Have a great rest of your day.